for attending this web event for diabeteshealthequity.org. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol Myers Squibb Foundation Together on Diabetes initiative. Here at PDHE, we represent the bridging of what we call the three necessary elements of effective diabetes care: clinic, community, and data. And we specialize in providing you opportunities to learn, share, and connect. Well, my name is Sabrina Jackson, and I will serve as today's moderator. Today's presentation is entitled Hearing Loss and Diabetes Comorbidity. It will be an engaging discussion with two audiology experts from Solace University in PA. As you are logging in, please weigh in on our poll question and give your attention to a few housekeeping items. Participant microphones are muted. If you're having any problems with sound, then please check your internet connection. I would also suggest logging out and trying to enter the room again. Please refer all tech issues to the tech support chat pod, which you will see displayed directly under Dr. Bray's photo. And as questions arise, please refer all presenter questions to the presenter Q&A pod. There will be a time designated at the conclusion of the webinar for discussion and Q&A. As a note, this webinar is CE accredited, so for those of you who would like to take advantage of this opportunity, please complete the survey that will be emailed to you at the conclusion of the webinar. And then we would like to invite you to join us on social media during this web event. You can tweet us at P4DHE, that's PFORDHE, using the hashtag PDHE. Again, that's P4DHE, using the hashtag PDHE. And now brief intros on our distinguished presenters. Dr. Kathy Dowd received her undergrad degree in French education from Spalding University. She received her master's in audiology from U of L and her doctorate from Solace University. In the last 5 years, she has worked to raise the awareness of chronic disease and ototoxic medications that cause hearing loss by traveling and instructing professionals nationally about the silent, unmet medical need. And we are excited to share that in April of 2016, her effective efforts moved the CDC to add a recommendation for hearing testing to the patient guide, Take Charge of Your Diabetes, a free downloadable resource that we will make available to you. We also have Dr. Victor Bray, who is an associate professor and a former dean of Osborne College of Audiology. He began his career in direct patient care and is now in his third career phase as academia at Solace University. He has earned degrees in biochemistry, audiology, and speech and hearing science. He has presented internationally at numerous workshops, seminars, and conferences on the clinical applications of audiology and has authored book chapters and numerous publications in audiology-related topics. So, without further ado, please help me welcome Drs. Dowd and Bray.
Thank you so much, Sabrina. And the title of our presentation is Hearing Loss and the Diabetes Comorbidity. Although in looking at audiology identification and management, we're also including vestibular or balance disorders that come from diabetes. As far as an overview of what we're going to be talking today, because I see in our poll question that many people are very interested in the pathophysiology of diabetes that causes hearing balance and cognitive disorders. So we'll talk about that. The identification and referral of patients that have diabetes for audiology diagnosis and treatment. What is an audiology evaluation? What are the treatment and diagnosis types? And then we'll talk about co-management of the patient, understanding and managing diabetic ear disease. So I'm going to turn this over to Dr. Bray for the next section.
Thank you, Dr. Dowd. The diagram we're looking at here is a schematic that shows the ear, and of course we're going to be concentrating on the ear and its two sensory input modes to the human system. One is the hearing system and one is the balance system. Dr. Dowd and I will refer to different parts of the ear. This outer part here is the ear canal. We refer to that as the outer ear. Looking in the ear, you can see the eardrum. Behind the eardrum are the smallest bones in the body that are called the ossicles, and that's the middle ear space connected with your throat by the eustachian tube. And then this area in blue is where the nerve elements are for the hearing mechanism, which is called the cochlea, and the balance mechanism, which is called the semicircular canals. This little area is encased inside the temporal bone. It's not something you can see and observe and study, and it's very hard to work with. And the inner ear and the vestibular section is connected by the 8th cranial nerve over to the brain stem and then to the brain. And most of the damage that we're going to be talking about today that is associated with diabetes occurs in this blue structure, which is the hair sensing mechanisms for the hearing and balance mechanisms. Now, you already know, I believe, that diabetes is a condition in which the body does not properly process food for use as energy. And most of the food we eat is turned into glucose or sugar for our bodies to use for energy. And the pancreas makes a hormone called insulin to help glucose get the glucose into the cells for our bodies. And when you have diabetes, your body doesn't either make enough insulin or can't use its own insulin as well as it should, and causes sugars to build up in your blood. And diabetes can cause serious health complications, including heart disease, blindness, kidney failure, and lower extremity amputations. And in this diagram in the middle, you can see the linkages of diabetes with respiratory, central, visual, breath, gastric, and urinary systems, both central systems and systemic systems of the body. Our expectation is that as the knowledge base about the pathophysiology of diabetes continues to explode and we learn more about hearing and balance mechanisms, future drawings of this diagram will have ears listed in, and this is where we're going to launch our talk in with you today. So I'd like to turn this over to Dr. Dowd.
All right, so when we talk about the pathophysiology of diabetes, whether it's insulin-dependent diabetes or non-insulin-dependent diabetes, and looking at both the hearing and the balance mechanism that's encased in the temporal bone behind the ear, what we see is microangiopathy and blood glucose effects on both the cochlea and the vestibular system. So for the cochlea, there's a very, very delicate vascular system called the stria vascularis, and if there's any disruption in that, it's going to disrupt the cochlea and what it's intended to do. The same for vestibular. With blood glucose effects, if that's affecting anything with the fluids that are in the cochlea and the vestibular labyrinth, then again you're going to get a disruption for balance effects. When you talk about nerve degeneration, you're talking about hearing degeneration and vestibular degeneration because both systems are connected to the 8th nerve. And then because the signal goes up to the brain to be interpreted, you may also have microvascular effects on the auditory cortex of the brain. So even as the brain tries to decipher what the ear or the vestibular system is sending it, there may be some interruption or distortion. Now this is a very good video. Unfortunately, we don't have the ability to show it to you today, but it's on YouTube. It's a National Diabetes Education Program video about diabetic eye disease. And the reason I wanted to talk about this because There's some of the similar pathophysiologies between diabetic eye disease and diabetic ear disease. What happens with diabetic eye disease and with the vascular system throughout the body with diabetes is that the vascular system may swell, it may leak blood into fluids that are not supposed to have blood in them. They may grow new tendrils which may weight down certain systems of the body. For the ear, this is critical. And in addition, what you see with diabetic eye disease is actual obstructions in the eye. Over time, they're going to start, patients will see spots floating in their vision, or they may notice a general blurring of vision. Eventually, diabetic retinopathy may cause vision loss and blindness. In addition, with the pathophysiology, you've got treatments for diabetes. And some of the medications that are involved with pain or with infection, which are high on treatment for patients with diabetes, are going to affect the viability of the hearing mechanism and also the vestibular mechanism. So there are pain medicines that are ototoxic and vestibulotoxic. For example, salicylates, aspirin, Darvon, Darvocet, Advil. All of these can have an effect on the ear or on the vestibular system. With infections, usually we're talking about very virulent infections such as Clostridium difficile or pneumonia. Aminoglycoside antibiotics are used to treat and get rid of these infections, and these also have a very strong ototoxic or vestibulotoxic impact on hearing and on your balance. So it's important before any of these medicines are prescribed or the patient starts them that they get a baseline and then they're monitored over time. In addition, if someone is comorbid with a cardiovascular disease and they're taking a loop-inhibiting diuretic such as Lasix or furosemide to get rid of the buildup of fluid in extremities or around the heart, those are going to have impacts on how the pain medicines or the infection medicines are cleared from the body because the loop-inhibiting diuretics are impacting the function of the kidneys. So there's a synergistic effect with Lasix and with gentamicin or vancomycin that you have to be aware of, and it may increase the impact on the hearing and also on balance. Be aware, too, that certain chemotherapy medications can affect both, which is cisplatin and carboplatin also have an effect on balance. So I'll turn the next over to Dr. Bray.
Thank you. So we've reviewed previously the structures of the ear, and we're particularly concerned with this blue structure, the inner ear and the semicircular canals, where the sensing hair cells are for our hearing and balance systems. And the pathophysiology that causes diabetes can also cause damage to these cells, causing progressive and permanent hearing loss. And hearing loss that occurs in this inner ear does not have a cure. And so when Dr. Dowd and I see patients with hearing loss that occurs at the inner ear, we are treating them with amplification and rehabilitation. There is no curative path. And the best way to treat this is to try to catch it early and to prevent the advancement of the diabetic disease so that we don't see the damage that runs concurrent to the auditory system. Now, what happens when somebody starts losing their hearing? The impact of hearing loss sets up a cascade of events that will start off rather benign but will become quite significant and will impact you in your care of the diabetic patient. The first thing is you get a reduced sensitivity to sound, usually in the high frequencies. Following that becomes reduced clarity of words as the high frequency sounds and then the mid frequency sounds just don't come through anymore. The person then has reduced communication ability. They have significant difficulty understanding what is being said to them. Once that communication breakdown occurs, there becomes a significant impairment on the person and their ability to interact with others. It impacts their employment. People with hearing loss are definitely set back in what they can achieve in their life in employment without good, aggressive audiological intervention. Also, the presence of hearing loss can impact communication and the social life. Specifically for you in this presentation today is it will impair the medical management of the patient. If the patient cannot hear you properly and cannot understand the message that you're giving them, they are not going to be able to understand what to do, and that is going to have a negative impact on compliance to the instructions and the training you're giving them. So one of the things we want to talk about today is how to identify and what you can do to help out in this situation. Identification of the hearing loss sometimes can be as very simple as some standard items that you're already familiar with. We sometimes joke about it a little bit, but the person saying huh or what is very common indication that they just can't hear and understand you because of the presence of hearing loss. Quite often, if you check with them, they can say, I can hear you, but I can't understand you. And that's because hearing loss occurs at some frequencies of sound, but not other frequencies of sound. They know that you're talking, and they can hear part of the sounds that you're making. They just can't hear them all. It's like trying to read a text where half of the letters have been cut out, and you have to fill in for what's going on. Other cues that you can look for in your office when you're dealing with a hearing impaired person, one very simple thing that people do is cup their hand behind their ear. We generally lose our hearing in the high frequencies, and cupping your hand behind your ear serves as an antenna that collects high frequency information, and it funnels high frequencies into the ear and helps that person hear better. Another way you can identify it is an interpreter or a third party. You're talking with the client, and the client then looks over to their third party to say and says, what did they say? And the third party, who's sitting close to them in a familiar voice, then explains what you said, and the person says, okay. And you end up operating through this third party interpreter. But confusion definitely results. And with that confusion, things that we're really concerned about is the decline in mental health and associating depression that can come with a patient. There's cognitive decline, there's confusion, there's isolation and stress. All of these have a negative impact on the quality of life. These are just from the hearing loss, not just the negative impact of having the diabetes. So the consequences for your patient management is that they have a failure to understand the verbal instructions, and the real-world consequences of working with these patients is misunderstandings and non-compliance with your instructions. Some simple things that you can do for in-office help to communicate with a person who's hearing impaired first starts with eliminating all background sounds. The presence of any competing sound with your voice in your office makes it very hard for the hearing impaired person to hear your voice and understand it. So radios, TVs, music, anything that's generating sound, turn it off when you're working with the hearing impaired client. Close your door, close your windows, just have your voice and their voice, nothing else. The second thing is that people naturally supplement their hearing loss by doing lip reading, and they want to watch your face. So sit face to face to them, use good lighting so that they can see your lips. That will help them. Talk at a normal pace, not fast. Talk at a normal level, don't shout, and talk with clarity, emphasizing your sounds. The one mistake that most people do is try to shout at the hearing impaired client. Shouting distorts your voice and actually makes it harder to hear. Shouting also can interfere with hearing aid signal processing and make it harder for it to process your sound. Normal, clear voice. If your voice isn't loud enough, the most effective thing you can do is just move closer to them. Every time you cut the distance in half between you and your client, you double the intensity of the sound they're hearing. So if you're sitting 6-8 feet away from them across a desk and they're having trouble, move away from around the desk and so go sit side by side with them. If you can sit just a couple feet away, you're going to dramatically increase the power of your voice coming in and their ability to understand you. So let me turn this over to Dr. Dowd now to talk about the other area of concern we have, which is vestibular disorders.
Thank you, Dr. Bray. So what we're going to discuss on diabetes and vestibular disorders is how vestibular impairment can result from problems in the inner ear or the central vestibular system. The pathophysiology that causes diabetes can also cause vestibular disorders. Again, we're talking about problems can be resolved with physical therapy. The impact of other vestibular disorders may be reduced through medication. But a vestibular disorder involves reduced ability to freely move about the environment without assistance of some kind. And the impact could be worsened with the diabetes patient because they're losing their vision and they're losing the sensation of feeling in their feet, the proprioception. So those are two very big inputs into staying upright and staying on balance. There's a frequent fall risk with subsequent injuries such as bone fractures. This is a huge issue for hospitals because when they discharge someone from the hospital, they want to make sure they don't go home and fall and they're back in the hospital with a bone fracture. And it's also associated with a decline in mental health because the person again becomes isolated and not able to move about freely. So in looking at diabetes and vestibular disorders, we're looking at dizziness, which is a sensation of lightheadedness, faintness, or unsteadiness. We're looking at vertigo, which is an actual rotational or spinning component. Or we're looking at disequilibrium, which simply means unsteadiness, imbalance, or a loss of equilibrium, often accompanied by spatial disorientation. But even a mild vestibular disorder can be much more problematic when it's accompanied by visual defect. The ability to compensate for vestibular disorder is compounded, again, when there's a deficit with proprioception due to the disease or an injury or where severe dizziness can result. What we do as audiologists when we analyze the vestibular system is we're looking at the vestibular ocular reflex. So we're looking at the fact that both the vestibular and visual systems are connected to each other and to the muscles in the eyes and the neck that help maintain good balance. Head movements or other stimulation of the inner ear will send signals through the nervous system to control the eye muscle movements. And this forms a reflex pathway called the vestibular ocular reflex, or the VOR. So when you get nystagmus, which is it's an involuntary, rapid, repetitive movement of the eyes. If you're looking at a patient and you ask them to watch your finger as you go to the outer visual capability, if you start seeing involuntary movement, that's what we call a saccade, or the eye trying to get back to a normal vision. Usually the movement of the saccade is side to side, but it could also be up and down, or it could be circular. But if there is nystagmus, this means that they need to be referred and assessed for a vestibular problems. So you see in the diagram on the right that both the eyes and the ears are connected through a neural pathway called the vestibular ocular reflex. As far as vestibular symptoms, you're talking about an inability to stand or walk unsupported with the eyes open or the eyes closed. That's going to show up if there's a vestibular disorder, and that's a reason for referral of the diabetic patient. You may see what the vestibular or the balance system is looking for is input from the visual system, from the balance system, the rotational gravity of the body, where is the body in space, and then also pressure or the feeling and the sensation at the bottom of the feet that tells the body and the brain where your body is located. Are you laying down? Are you sitting down? Or are you standing up straight? And that input is going to then generate the output of an ocular reflex, postural control to catch yourself if you're falling, and also vestibular symptoms could include nausea. So I'll turn the next slide over to Dr. Bray again.
Thank you. I'd like to talk to you a little bit about the prevalence of audiology disorders with diabetes. One of the major sources of information we have is the epidemiological study of the National Hearing and Nutrition Examination Survey, and the 2008 publication from the Archives of Internal Medicine specifically looked at hearing loss and diabetes in the U.S. population. And the first thing they found, which was interesting, is that hearing loss was more prevalent among the U.S. adults than had been previously reported. It had been thought that it was about 10% of the population. And the hearing loss prevalences were higher among participants with cardiovascular risk, and there's a trio in here: hypertension, diabetes mellitus, and heavy tobacco use. So that cardiovascular risk associated with tobacco, diabetes, and hypertension is all related into increased risk of hearing loss. For the NHANES study, the presence of hearing loss in the population was found to be between 12 and 19%. If you allow me to round that off, I'll call it 15% of the population. And with the presence of diabetes among the people studied, the occurrence of hearing loss is increased by a factor of 2 to 3 times. If you take 15% and increase it 2 to 3 times, that puts you somewhere in the neighborhood of around 40% of the population that you're dealing with diabetes could be presenting themselves with hearing loss. And that, I think, has got to be a significant concern for you in managing these clients. The main recommendations for the NHANES report were that cessation of smoking, reduction of noise exposure for noise-induced hearing loss, and effective treatment of diabetes and hypertension can delay the onset and the progression of hearing loss. So you can actually help your patient by managing the diabetes. Diabetes is not the only area that's associated with hearing loss. Just to give you an idea, other comorbidities and chronic conditions that occur that are related to hearing loss are problems with the musculoskeletal system, digestive system, respiratory system, nervous system, circulatory system, and malignancies or cancer. And you also know, I'm sure from dealing with the diabetic patients, that many of these systemic disorders are comorbid with diabetes. So you're seeing in these patients quite a strong presence of the compounding effect of a lot of chronic diseases resulting in syndromes which include the hearing loss. So let me turn this back over to Dr. Dowd to talk to you about the evaluation process.
Have diabetes or pre-diabetes, basically without any sort of chronic disease, I would say anyone at age 50 or older needs to have their hearing tested. But certainly when you're diagnosed with prediabetes or diabetes, you need to get a baseline hearing test and a balance screening to find out what is the current picture of your hearing. What are your thresholds? What is your ability to process speech and speech in noise? The audiologist, when you go into the audiologist, they're going to be able to tell from your case history if there's any other reasons for your hearing loss in addition to diabetes, if you're exposed to noise, if you're on ototoxic or vestibular toxic medications. So the audiologist will go in and you have the baseline hearing test. They're going to tell you when to come back, when to have another evaluation. Certainly for diabetes, at least annually to monitor the hearing levels. What you have to understand is a hearing loss is an invisible handicap. Me talking with anyone in my family, if they're not hearing me, I'm thinking they're not paying attention. Or they're starting to lose it. They're starting to get confused. It's a silent epidemic. So certainly just with the diagnosis of diabetes or prediabetes, get the person tested for a baseline, and then let the audiologist make the recommendation for monitoring and treatment based on the history of the patient. Who can sign orders for audiology? Audiology requires a physician order for testing and evaluation. So we can get orders from clinical nurse specialists, clinical psychologists, clinical social workers, interns, residents, or fellows, nurse practitioners, physician assistants, physicians, which could be a medical doctor or a doctor of osteopathy. We can also get an order written from a dentist, a podiatrist, or an optometrist. So if an optometrist is seeing someone for a vision exam due to diabetes, it makes sense to refer them on to the audiologist for a baseline or for monitoring of their hearing due to medical necessity of diabetes. When you talk about who evaluates hearing loss, and I think I may have mentioned CDC is now actively looking at the recommendation of patients getting their hearing checked, there's three professions that work with patients about hearing. The first is the medical doctor, the otolaryngologist or the otologist. They will work with a patient that has medical issues with their hearing, or they need surgery to correct their hearing, and that occurs 15 to 20% of the time. Then there are audiologists, and basically audiologists have a master's or clinical audiology degree, doctorate, or a PhD. Their certifications include the American Board of Audiology or the Certificate of Clinical Competency in Audiology. But they perform both audiological and vestibular evaluations, and they make the referral on. Once they assess what's going on with the hearing, they will find any underlying medical or surgical need and refer that patient probably back to the initial person that referred them, but ultimately then that patient needs to go to the otolaryngologist. For diagnosis and treatment, the audiologist will manage the hearing loss. They will do oral rehab, including hearing aids. They will counsel with the patient on family, job, and school communication. They'll do tinnitus evaluations and treatment methods. That's if you have a ringing in your ears or a roaring in their ears, they can evaluate and treat that. The other profession, which I don't have on here, are hearing aid dealers or hearing aid specialists. These are people that only dispense hearing aids. They will do a hearing test only for the purpose of dispensing a hearing aid. In some states, you don't even have to have a high school education. Most states use the high school education as kind of the ground floor entry into the profession. But these are comparable to the opticians who dispense the eyeglasses. So again, for diagnosing the hearing loss and finding out what the underlying cause is and which direction they need to go, you're first going to go to the audiologist. And I'll turn it over to Dr. Bray to explain the audiogram.
Thank you. When you make your referral and the person undergoes a hearing evaluation and you get a report back, you may very well see a graph of the person's hearing that comes back to you, which is called the audiogram. It's probably the most common piece of information that we communicate back to our referral sources. It's just a graphic representation of hearing thresholds, and it's very important that you be able to, I think, understand how to basically read this. It's an XY plot where low pitches are on the left and high pitches are on the right, and soft sounds are at the top and loud sounds are down at the bottom. And when we evaluate hearing, we evaluate sensitivity. So for low-pitched to high-pitched sounds, we just vary the intensity of sounds until the person begins to hear them, and we plot those points on the graph. If all of the points plot across the top of the graph in that yellow zone, the person has normal hearing. So if you get a report back and all the numbers are up in here, the symbols are in normal hearing, you're in good shape. The further down you go, the worse the person's hearing is, and if you see this down in here, in this gray area of a profound hearing loss or deafness, you've got almost a total loss of hearing. The linkage here, which I've shown to you, in the bottom, the YouTube video here, is a nice little Flintstones video that you can check out. It's about 1 minute long and describes and has audio simulations. What we've done here is to take the audiogram of pitch and intensity and overlay it with where speech sounds are. Usually, a person first loses their high-frequency hearing out here. That's where we call the fricatives, the F and the S and TH. They next lose their mid-frequency hearing, which is where the affricates are, the ch and ch sound. And finally, the last to go is the low-frequency sounds, which are primarily the vowels. And an easy way to summarize and understand what's going on with hearing loss, a person says, I can hear you, but I can't understand you. They're hearing the vowels, but they're not hearing the consonants. Cat, fat, mat, all of those may sound the same because they can't hear that first consonant. Thus the confusion in understanding. By the time a person gets a moderate loss of hearing, they're having significant problems, and they typically will need hearing aids in order to understand you, and they need to continue to use lip reading cues. So maintain your good communication role that I've taught you earlier. This audiogram here from the Flintstones video shows the audiogram, and it's showing you the loss of high frequencies in the high-pitched sounds. The next audiogram shows a severe hearing loss where you see the audiogram comes down in here and we're losing the mid-frequencies and the high frequencies. This person is going to have severe difficulty with understanding speech in the day-to-day communication, and they must have intervention if they're going to have any kind of communication ability, whether it be at home, in social life, in employment, or with you. In terms of making the referrals, recommend that you make the referral to the audiologist so that, as Dr. Dowds mentioned, we can establish a baseline function on the person. I also recommend that you make the referrals rather than trying to do some of these screening tests yourself. You don't need the training to make the referrals. You do need the training to do the screening tools. Many of the screening tests that we use are take office time, and you will not be compensated for doing those. And if you make the referrals, you're going to get a full evaluation and report. So again, that's my recommendation, is making the referrals when you suspect something rather than trying to do a variety of screening protocols yourself. But let me turn this over to Dr. Dowd, who can talk about the protocols that we would use.
All right, thank you, Dr. Bray. And I realize that we're using up our time. I have 4 slides here, which I'm going to run through quite quickly. There is a protocol for vestibular and fall risk management. There's a screening protocol, which could just be a timed up and go test. But when you do, and the audiologist may do the screening protocol to begin with because they understand that, but they'll then do an advanced assessment, which may involve dynamic posturography, standing up, and actually computerized analysis of how their posture is, how their eye movement is using a camera and goggles, using a rotary chair. On auditory and hearing management, there are screening protocols. You could do an interview of the patient, but it really has to involve the family members if you're going to use that type of screening, because the patient themselves doesn't realize they've lost hearing. They lose it so gradually. There's questionnaires, again, that you can give the patients, but that may not show a problem if the patient doesn't perceive it. They think they hear fine because they hear certain sounds just great. So really it's best to go to the audiologist and get audiometry, tympanometry, acoustic reflexes, OAE, which is actually examining the outer hair cells in the cochlea to see if there is starting to be a disruption in hearing. It may not even show up on the audiogram yet, but OAEs will show that, yes, there's starting to be a decline in hearing. When you look at insurance coverage, it really varies state by state for adults. The Medicaid coverage. Children are always covered under Medicaid and by insurance for hearing and hearing aids. That's a relatively new coverage. But you can go to this link on hearingloss.org and look under Medicaid regulations to find your state and see what your state does for adults. They may cover it, they may not cover it. Most insurances cover almost all insurances cover diagnostic. Medicare, Medicaid, they'll cover the diagnostic for hearing and vestibular assessment. But some of the employer insurances now have plans for hearing aid coverage. Medicare Advantage, they're starting to pick up hearing aids in their coverage, but regular Medicare Part A or B does not cover hearing aids. So what happens, where do you go to cover the cost for the uninsured? Again, children are always covered. Adults, when there is no coverage, then you're going to have to look for alternative coverage in your community or in your state. It may be vocational rehab, it may be United Way. In North Carolina, where I am, vocational rehab has a lot of coverage for hearing loss, whether it's independent living, which is for seniors. Mental health coverage will also cover hearing loss. Hearing impaired services for those working that need help. But a lot of times there may be an out-of-pocket expense. So most of the audiological evaluation in vestibular is covered. The hearing and balance rehabilitation sometimes is covered and sometimes not. Sometimes we have to make a referral to physical therapy for the balance coverage. And the hearing aids, really with the, there's new reports out with the PCAST and the IOM now trying to reduce the cost of hearing aids and improve access. The cost could depend on your lifestyle, though. If you're not getting out much, you may not need the most sophisticated technology. But the normal recommendation is both ears. If both ears are affected, you have to have both ears corrected. So I'll turn over to Dr. Bray for a summary here.
Okay, thank you, Dr. Dowd. So this is our last slide of our presentation. I want to walk through you the map that we've used for our presentation for you, just hitting on the key points again. We're talking about the diabetic patient, and there's two avenues of concern that we're talking about. One is the pathophysiology, because while it's unknown exactly what the pathophysiology is that is associated with hearing loss, the discovery process is underway, and we know that this is going on. It's associated with the cardiovascular problems. Secondly, the diabetic patient is taking medications, and those medications can affect the hearing system, they can affect the vestibular system, and they can affect cognition. So you can have an impact on your patient in two different paths just by being the diabetic patient. In fact, they could be affected by both paths, the pathophysiology and the pharmacology. And you end up with hearing, vestibular, and cognitive disorders leading to social consequences. And we're relying on you and your observation of the client. Again, if we use the rule of thumb that about 15% of the 15% of the U.S. population is hearing impaired, the prevalence of hearing loss and diabetes is 2 to 3 times that of normal. You're talking about 30 to 45% of your patients could be coming in presenting with hearing loss. So certainly a third of your patients are coming in with symptoms of hearing loss. We're relying on you to refer them for audiological management, and of course our goal in the management of that is to restore their communication abilities and get their communication abilities back functioning so that they can improve the patient compliance when they work with you. Thus, better management of the diabetes leads to better management of the hearing loss. So thank you very much, and I understand we'll be turning over this now for some questions.
Test, test. Can you guys hear me okay? Okay. So we did have a few questions that we wanted to throw out here with you guys, and some of these were submitted beforehand. We would also like to now open up the time to participants. If you have any questions now, you can go ahead and submit them into the Q&A box that's located at the bottom of your screen. So we'll first go to treatment. And this question is about prevention. So what preventive measures are recommended for patients that are covered by insurance? So in terms of hearing loss and diabetes or other chronic diseases. And either of you can weigh in on that one.
How can you prevent hearing loss? Well, obviously, good management of the diabetes is going to make a difference. So if the patient is compliant with their medication, if they understand the doctor's instructions, if they're doing everything that the diabetes educator and the physician and the nurse practitioner feel that they need to be doing, that's important. From the standpoint of audiology, they have to make sure they're not around noise, lawnmowers, leaf blowers, chainsaws, because they may be at a higher risk of noise exposure if they're diabetic. So making sure if they're running the lawnmower that they have ear protection on, or if they go to loud concerts or car races or anything where there's a loud continuous noise.
I would second that, in that this gets back to the key point of where this hearing loss occurs. And we work very closely with ENT physicians, and when we identify hearing losses that are medically or surgically correctable, we're always working with the physicians. Unfortunately, this type of hearing loss of the inner ear is not surgically correctable. It's not medically correctable. So what Dr. Dowd was talking about, which comes into lifestyle choices. The first of those is attacking this cardiovascular trio of smoking, hypertension, and diabetes, getting those under control, and then the other one of avoiding noise, because that diabetic ear looks to be fragile to noise exposure. Those are the lifestyle choices where the person can, through your counseling and with your patients, if you can get them to take action in those areas, that's the best thing you do. You can't prevent the hearing loss once it's occurred, but you can stop the advancement of it.
Thank you. And again, I'd like to encourage our participants to type your questions in the Q&A pod at the bottom of the screen, the presenter Q&A, rather than the tech support screen. So here's a question. Are there any specific profile, is there a specific profile in terms of frequency configuration that you typically observed in diabetics? And in terms of balance or vestibular patterns, do you see a typical one for patients with diabetes?
I think what we're seeing is that it could be a low frequency drop-off, it could be a high frequency, it could be an ultra-high frequency drop-off on the audiogram, and not all audiologists test out to 20,000 hertz. So you may start seeing a decline if you're in research with some of the ultra-high frequencies, but we can actually, with the OAEs, the otoacoustic emissions, we can start seeing some degradation in the cochlea even before it's seen on the audiogram. As far as balance and vestibular patterns, no, I've not looked at any of those, any of the research on that, although there's a phenomenal clinician in Florida who has the American Balance Institute, who says with diabetics he does see much more of a risk of falls and balance issues.
Yeah, Dr. Dowd, I remember that presentation by Dr. Gans also, and the figure that he's working with in his practice, and it's 70% increased risk of falls for the diabetic patient compared to the non-diabetic patient. And definitely studies just published this year looking at where the where the malfunction is in the ear. The otoacoustic emissions are showing pathology or impairment in the cochlea. The ABR tests are starting to show impairment in the eighth nerve and connecting into the brainstem. And there is also a study that just came out from Indiana that was showing central auditory processing disorders associated with diabetes, especially with the processing of information in the time domain. So it seems to be attacking the auditory system in many, many different ways.
Okay, thank you. There's another question. Is pain ever a symptom reported?
With a hearing loss, it could be if someone has an ear infection. Somebody might have had pneumonia, and the fluid got up into the middle ear space, and the pressure or an infection could actually cause pain. But I think if it's a permanent type loss, I've not ever had anyone experience pain with decline in hearing. Now, balance, if you lose your balance, there's some pain there if you fall.
Yeah, and certainly I agree, Dr. Dowd. If you get a disorder of the middle ear, if you get a trauma to the outer ear or the eardrum, if you get a disorder of the middle ear where you have fluid behind there and it's an active infection, there's pain and there's discomfort. But the type of hearing loss that we're talking about, or vestibular impairment in the inner ear, there really aren't any pain sensors there. And the only thing that we've ever, I think, encountered pain is where we have somebody who's been exposed to an extremely loud sound. I mean, so loud that it creates instantaneous damage to your hearing. That can hurt. And if you have that happen, the after effect is hearing loss. But no, as Dr. Dowd mentioned earlier, hearing loss is invisible. And it has no pain or no discomfort, nothing at all associated with it that it would, as a normal identifier, to cause people to come in and seek medical management. They don't come in and say, it hurts here.
And we've had this question asked by more than one person. Which medicines for diabetes tends to put patients at risk for hearing loss?
That's a very interesting question, and we actually have an audiologist who's done a review of all the insulin medications. I can't tell you just off the top of my head, but he reviewed for both hearing, balance, and cognitive effects of these medications. So if you go to our website, theaudiologyproject.com, and go to the blog section, his report is there, and you can actually look for every single medication, you know, what the potential effects are. And everybody has a different sensitivity to the medications. Sometimes it won't affect anybody, these medications, but other people might be very sensitive, and just one dosage might have an effect. So you have to be aware of those, and you can look at the list that's posted.
Dr. Dowd, would you repeat that website address again?
Yes, it's theaudiologyproject.com.
Okay, great. Have you noticed, Dr. Bray, did you want to comment on that question as well?
No, Dr. Dowd is the executive director of the Audiology Project and has put together marvelous materials, and I would just recommend you try the Audiology Project website.
Okay, another question that came up more than once is there an association with hearing loss and average A1Cs?
We don't know at this point. We do know from the epidemiological studies, like the N. Haynes study that's just been, people have been the main data mining source for studying what's going on in the population. The definition of diabetes that's been used to classify people is a non-fasting blood sugar level of 200 milligrams per deciliter, or a fasting level of greater than 126 milligrams per deciliter, which, if I understand right, is an A1C level of maybe somewhere around 6.5%. But I think you have to help me with this. What we have observed is that the consequences on the auditory system, though, can actually occur in the pre-diabetic stage. So the auditory system is sensitive all the way through, and as of now, we do not have any information that directly correlates A1C levels with certain degrees of impairment. We just know that they're associated and related, and also probably progressive. Higher A1Cs going to lead to greater probability of problems with the eyes, problems with the feet, and problems with the mouth, and problems with the ears.
Okay, and one last question. Has any of your research shown that there's a correlation between men or women with diabetes? Do they experience similar levels of hearing loss, or have you noticed that men or women tend to have that more? Dr. Bray.
The main thing that we know from our population data is that among diabetic patients, there's a greater occurrence of hearing loss in the men than among the women. But that also occurs in the population at large. Men can be 1.5 to 2 times more prone to the presence of hearing loss due to noise overexposure to their ear during the course of recreational noise or occupational noise. And that underlying factor of these ears that have been already pre-damaged carries through and shows up in the diabetic data where men are showing more. But it's not that we know that it's necessarily related to diabetes. It's related to the history of occupational and recreational noise exposure. We're not aware of anything that's gender-related having to do with diabetes and sensitivity of hearing systems.
Okay, now this is the last one, really. So, what studies are underway to evaluate further the connection between diabetes and hearing loss? We are glad to know that Dr. Dowd is working with the CDC to do more guidance in screening and in terms of treatment, but are you aware of any current studies to evaluate this issue further?
There are some ongoing studies now. I spoke with a researcher just this morning who said she is getting ready to go into a large study at the University of North Carolina at Chapel Hill for Latin American residents. She said the population base that they have is 16,000 people, and she's an epidemiologist, so she's basically looking at the testing, what test would most accurately identify these patients who have hearing problems. The VA is doing some testing with ABR, which I think is still active, and they don't have all of their data in. So there's still a lot of research that hasn't even started for things that we now know about this, but those are the 2 active ones that I'm familiar with right now.
Thank you. So with that answer, we need to conclude as we're right up against time. Audience, please help me in join me in thanking Drs. Dowd and Bray for an informative and engaging presentation. I would like to say for those of you in the audience that there were several questions that we didn't get a chance to address, so we will make sure to get those questions to our expert speakers and have them weigh in by text, and we can send those out to you, disseminate those to you in form of newsletter or an email summary. The links also that they shared through the presentations that we did not have time to show those videos, we'll make sure to summarize that as well. For those that are interested in getting CE or attendance for this web event, there will be a follow-up email that gives you directions to do a survey or an assessment and to attain that. And so I would just again like to thank you for joining us here today for this Diabetes Health Equity web event. Please join us on our website for your online education and training center for all things diabetes and health equity. While you're there, please be sure to check out what's new this week. You can always contact us directly if you have any questions at info@diabeteshealthequity.org. And of course, you can always connect with us on social media. Please tweet us at PFORDHE and use the hashtag PDHE. As a final reminder, here at the Partnership for Diabetes Health Equity, we aim to serve you as a national online resource and training center. If you have needs, ideas, comments, or suggestions, do not hesitate to reach out. Together, we can achieve health equity. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol-Myers Squibb Foundation Together on Diabetes initiative. Thanks everyone for attending, and have a fabulous rest of your day.
Thank you.
Thank you.